With cardiogenic shock, surgery is needed, including coronary artery bypass, ventriculoplasty, or heart transplantation. You will also need cardiosupportive drugs and fluid regimens, as well as continuous hemodynamic monitoring. So here's your first question on shock. A person develops cardiogenic shock after an acute MI. The nurse understands that this will produce one, inhibition of the sympathetic nervous system, 2, stimulation of the renin-angiotensin system, 3, decreased activation of the complement system, or 4, lowered production of the catecholamine system. The answer here is 2, stimulation of the renin-angiotensin system. As cardiac output decreases, compensatory adaptive responses are activated, such as the renin-angiotensin, neural, hormonal, and sympathetic nervous system. This leads to fluid retention, systemic vasoconstriction, and tachycardia. Next, on to hypovolemic shock. This occurs when there's an insufficient intravascular fluid volume. It includes loss of whole blood, blood plasma, or interstitial fluid, or fluid sequestration. This can be due to hemorrhage or burns, emesis, or diuresis. It leads to compensatory vasoconstriction, increased systemic vascular resistance, and afterload. It also, to improve blood pressure and perfusion to core organs, there's always a compensatory mechanism. What you'll see here as far as clinical manifestations include poor skin turgor, thirst, little to no urine, low systemic and pulmonary preloads, and a rapid heart rate. Treatment include prompt control of the hemorrhage and fluid replacement. On to neurogenic or vasogenic shock. This is where there's a widespread vasodilation and occurs from an imbalance between the parasympathetic and sympathetic stimulation. This causes persistent vasodilation and creates relative hypovolemia. Blood volume is unchanged, but the amount of space containing the blood has increased, therefore the SVR decreases. Pressure in the vessels is inadequate to drive nutrients around the capillary membranes, and nutrient delivery to the cells is significantly impaired. This can be caused by severe pain, stress, anesthesia, as well as depressant drugs. Clinically, it manifests as a very low SVR and bradycardia, and treatment here is to control the pain. Anaphylactic shock is the outcome of a widespread hypersensitivity, be it to an allergen, that triggers a reaction known as anaphylaxis. Allergen causes an extensive immune and inflammatory response where there's massive vasodilation followed with a fluid shift into the interstitium. What you'll see is widespread hypersensitivity reaction, and it leads to vasodilation, peripheral pooling, and relative hypovolemia. Other pathophysiologic effects cause a more severe reaction. You'll see anxiety, difficulty breathing, gastrointestinal cramps, edema, hives, sensation of burning or itching of the skin, fever, and hemolysis. Treatment includes removing the antigen, epinephrine, which decreases mast cell and basophil degranulation. It also, in turn, causes vasoconstriction and reverses the airway constriction, as well as IV volume expanders, such as lactated ringers, and antihistamine and steroids, which stop the inflammatory response. Another shock that you may come in contact with is septic shock, and this is an infectious process that initiates septic shock. The 6 most common infection sites are the lung, bloodstream, IV catheters, intra-abdominal, area, urinary tract, and surgical wound. Bacteremia, endotoxin, and exotoxins cause the host to initiate the inflammatory response. That in turn activates the complement system, coagulation and kinin system, and cellular immunity. It initiates and promotes widespread vasodilation. This is a nice picture that depicts septic shock progression from a systemic inflammatory response to sepsis, in turn to severe sepsis and septic shock. Clinical manifestations of septic shock include persistent low arterial pressure, low SVR from the vasodilation, and an alteration in oxygen extraction by cells. The treatment includes to check the lactate level, obtain blood cultures, start an antibiotic and antifungal medications, implement a fluid challenge to see how patients react, and achieve goals for blood pressure, CVP, and central venous oxygen saturation. Neuroepinephrine is also the vasopressor of choice. Septic shock, unfortunately, has a very high mortality rate. So here's your second question. Which laboratory result should the nurse check for a person with suspected septic shock? Would it be hetastarches, immunoglobulin E, lactate, or antigen titer? The answer here is lactate. The current guidelines for severe sepsis and septic shock recommend immediate resuscitation in people with lactate levels greater than 4. Elevated lactate levels indicate tissue hypoperfusion, and patients should be entered in early goal-directed therapy of resuscitation within 6 hours, regardless of blood pressure level. On to multi-organ dysfunction syndrome. MODS is a progressive dysfunction of 2 or more organ systems